And the other thing is don't rush it. A lot of the times, especially with shoulder pain, I think, when something doesn't start to respond in 2 or 3 weeks, patients and physios start to panic. I'm like, just hold your nerve. Don't panic. Most of these things, again, the evidence and my experience says give it a minimum 3 months, minimum, sometimes even longer. We've just done a paper, me, Chris Littlewood, and a few other authors, we got together and we just come up with a consensus of what us quote unquote expert shoulders, using the evidence base as well, stipulate for subacromial shoulder pain. And again, lots of things have come out with lots of uncertainty, but a couple of the things that come out is just we don't give things long enough. We panic, we intervene, we overtreat because things are just not given time to respond to the physical therapy, to the exercise.
When's that paper coming out? I want that.
Don't be too hopeful, because there's lots of uncertainty in it. One thing it tells us, we've got shitloads more work to be doing for subacromial shoulder pain, is just that we've got very little in the terms of, what's the best exercise, what's the best frequency, what's the best parameters. It's very ambiguous, but I think it's good because it just allows everybody to chill out, gives everybody this sort of scope to say, look, there's not one specific protocol that's better than the other. What we've got is this big sort of open field of different selections of exercises, isometric, concentric, eccentric, different load variations, different rep ranges, different sets. All we've got is we know it's going to take about 3 to 6 months to start to show effect. You need to do it about 3 times a week, and it has to be at sufficient intensity. And again, it's a bit ambiguous, but we're looking at sufficient intensity for it to create, obviously, physiological or psychological adaptations. And that's about it.
Those should be people's favorite reads. I shouldn't say that but shouldn't speak for other people. But that should help us. I mean, there's nothing that gives me more reassurance than knowing that we actually don't know anything, because then I don't have to worry about all the extracurricular things that I'm seeing everywhere. And okay, I was like, I'm not missing the boat by taking that approach. That's how I feel when I read papers like that, and I think they don't get the attention because they're not, because of the uncertainty, I think. But that's a misconception. That's the benefit of reads like that. And you made a good point. People want diagnoses, or they don't. I'm sorry, flip that. People ultimately want the plan and they want the prognosis. I feel that sometimes we as practitioners think that the patient wants a diagnosis because we want to figure out a diagnosis, because that's a me thing. I'm the doctor. Yeah. I want to figure out what's wrong. The patient must also want to know exactly but not really. They're coming in there to know when they can do the thing that they want to do again.
Absolutely. One of my idols in physiotherapy, God rest his soul, is no longer with us now, Louis Gifford famously said it, patients want to know 5 things. They want to know why they hurt, but you can be ambiguous with that and be reassuring with that it's nothing serious or sinister, because that's point number 2. Is it serious? Often at the times it's not. How long is it going to take? What can I do about it? And how much is it going to cost me? Because they're the things that play on patients' minds. So again, they're the things. Louis' golden 5, as I call it. I try to make sure every sort of initial appointment and follow-up appointment, I'm going through those key points with a patient and making sure they're aware of them.
The other thing that you said that I think is a key point is the expectation of the process of rehab. Even in an acute setting, when you said that, after a couple weeks, people start to get antsy. Even the clinician starts to panic a little bit because they know, there's going to be some pushback. But do you feel that if expectations are set right off the bat, the patient knows exactly what the minimum, because none of us know how long this is going to take. Well, how long is it going to take? Well, I don't actually know, but I think that at minimum you commit to this amount of time. Like you said, 3 months, have in your brain 3 months minimum. Then after 2 weeks, if nothing has changed and the patient's like, well, what's going on? You can say, hey, remember first day, you signed off on the fact that this is going to be a process. Do you feel like expectations right off the bat are important?
Absolutely. I think it's key. And again, I think physios often do a bad job with that. And I think, again, it's because of their training in the background. Everybody wants the quick fix, and that's why I blame manual therapy for so much shit, because the pressure is on removing the pain immediately within session. 20 to 30 minutes, make my pain feel better. I'm like, no, why? if it does remove your pain, it's not the answer. It's only the short fix for a very short period of time. So again, I am a big believer of explaining to patients that, most of these things that we see in the musculoskeletal world are not quick fix or not resolvable within a couple of weeks. Some do, but most of them don't. They just got to stick the path. They've got to accept it, and they've got to start getting on board with it from day one. So I think, again, setting those expectations with the patient on that first initial assessment is absolutely fundamental and key. And a lot of patients I know, and I've got this as well, a lot of them will get antsy about it. They'll get annoyed about it. They'll get pissed off about it. And they don't believe me, and they'll say, oh, but so-and-so said I had so-and-so. And I say, well, I'm not saying it's definite, set in stone, but, from my evaluation of what's going on here, my experience of what's happened with thousands of other patients that I've seen in the past, this is my expectation of what will be happening for you. And again, it's something that I think, some patients will tolerate, other patients won't, and they'll go and see somebody else, and that's their choice at the end of the day. But I am very much, like you say, a believer of just making sure the patient is aware of the expectations in the first session.